Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Guys, welcome back to the Low Carb MD Podcast. I have a new rising star. I shouldn't say rising star. She went and she presented at the SMHP conference in San Diego, the Society of Metabolic Health Practitioners. And immediately afterwards, I'm getting calls. Who is she? She's amazing. She was the star of the show. Oh my gosh, I'm so happy to have back the endocrinologist, the clinic lead, and now an author. I'm so happy to have Dr. Roshani back here. Super excited. Got the book. Love the book. Thank you so much. We were talking. I'm a huge fan of your work. You know that. But we were talking a little bit off the air on the different areas of metabolic health, the different sides of metabolic health. There's the clinicians, there's the activists, there's the evangelists, and I want to start right there. We won't name names, but how do you see you having an impact on your world and your clinic and your community there in India? I know you've said before on our podcast, it's been a bit lonely. Is it still lonely? How do you see the evangelists having an impact? How do you see, the health coaches, which I know you have working in your clinic? How do you see them having an impact? Maybe we could start there. How are we going to have an impact on our communities, on our families, on society in a whole, and as a medicine as a whole? So first of all, thank you for coming. And there's your first question. That's a hard one.
It's a hard one, Tro.
Yeah.
Thank you for having me. And it's a Saturday morning. You're working hard and busy. So thank you for the time, in spite of all the publications and work that you're doing to make people aware of what's possible. So yeah, thank you for your kind words. We need one of every of the categories that you said. We need the clinicians, we need the converted patients, we need the evangelists, we need policymakers, we need one everywhere, and my sort of the cartoon in my head is we need one person in every home to get converted. We need to infect one person in every group with this idea that low carb or lifestyle change or lifestyle first as a way of life or as a way of health helps you prevent and reverse metabolic disease. If you look at just maybe one common thread, what are we fighting? It's insulin resistance and everything that drives that. And many people are joining this tribe now. And even within this few months between our last conversation and now, there is definitely more hope everywhere in the world, even in India. There are more groups coming forward, more evangelists, more startups, more funding, more advertising, more companies, more teams, more coaches. It's happening. There's more awareness of keto, LCHF. These words are not totally foreign. You still have the naysayers who really haven't read anything in maybe 20, 30 years, or they're still sort of going by the low fat, low calorie approach. Even though that has miserably failed. So we are seeing this pushback. It's still lonely in the physician community for me in India in terms of doctors. I have a few trusted people that I can count on my fingertips who understand the work and who, they are happy when their patients come back to them saying, I did some work over there with Roshani's team and they taught me all this stuff and now I'm better. I'm losing weight. I'm losing inches. I'm getting stronger. So doctors are probably amongst the slowest to convert, I think, Tro. And I think what you all are doing with SMHP to create the scientific basis for it, where we're not just YouTubers. we're doing serious stuff. We are honoring our profession in the best way we possibly can. We're trying to be as true to our oaths as possible, is we came in here to heal. So how do we do it? I think my effort in that direction was the book, and to be speaking at the SMHP about communication. That was the point that I had made on stage, was how can we listen to each other better? That was the essence of my talk. There were so many experts who were already teaching us about low carb and keto and so many important topics. So I went into the soft skills space of communication. And I think people liked it because we face it every day. Even if we have to get this message out there, it's only going to happen through communication. So maybe that's one space that we can work on.
When it comes to communication, it's interesting. We've heard this topic before. First of all, I agree with everything you said, and the book is absolutely amazing. So guys, we'll put it in the show notes. Absolutely go get a copy, and we'll have all those details there. But let's just focus in a little bit about what you said in communication. Communication styles and communication personas and archetypes. There's so many different things that resonate. For us as clinicians, what do we want? We want refined sort of communication with citations, right? But what does the average person want? They want the no-nonsense truth, right? They want, and they don't mind, I don't want to say, they don't mind a bit of evangelical commentary, right? Brian always criticizes me for using profanities on Twitter or using profanities in general. But I think, there's a lay public out there that's just tired of the refined commentary from, the CDC and the FDA and the academics at Harvard, and they just want to feel real. And right. I think, what place do you think that type of commentary has? Because I think our initial gut instinct is to say, this is not how doctors should talk. This is not how a metabolic health practitioner should talk. But right. what if we needed, I'm not trying to convince the ivory tower. I'm not trying to convince the CDC. I'm trying to save that. You said it yourself. We need to convert one person in the home.
Right.
How are we going to convert that one person in the home with communication? Help me, because I'm a Twitter communicator. So you're giving me therapy right now.
Well, yeah. That's the blessing. It's a blessing to be able to talk like this to each other. It's important to be passionate. It's important to be emotional and be real. I agree with you that if we stick to a script and be all proper and talk the way our certificate is supposed to talk, it won't feel human. And I think it's more important for us to be genuine. And you do that. It's social media can be unsocial sometimes. It can be dehumanizing because of just the way a screen is. You don't see the person's response to what we're texting or typing, and the nonverbal cues that might come in communication. We lose that. And if let's say, Tro, I said something to you really passionately, I feel so strongly about it, and I just throw it at you. And then I sort of see your face or, eyebrows or shoulders or something move in a way that instantly, without even analyzing or realizing, I know I didn't land that right for you. I get to course correct because I don't want to hurt you, and nor do you want to hurt your audience. None of us want to hurt any of our community. Sometimes social media can be troublesome that way. And I guess in the limited power of speech and language that we do have, because we have words, and words don't always do a great job of communicating feelings. There's a gap there, and the joke I use to explain this to patients, right? I'm going to take a slight tangent to come back to your question, is sometimes when you ask a patient about emotional eating, they won't be able to explain it to you in words, why it happens or what exactly happens. It's almost a felt energy, the urge or the strong momentum that takes over. And it's hard to put emotions into words. Or if you say to someone, how did you know when you first fell in love, with the love of your life? It's difficult verbalize it. And we try so hard. And so to come back to what we're trying to do on our screens, I don't know. I mean, sometimes it's the edge, right? Is to be evangelical without being disrespectful. That's the edge I'm talking about, is I'm okay with being passionate or powerful or forceful and convincing.
You are those things, by the way.
Thank you. Hopefully
Yeah.
in the right way, right? In the right
No,
direction.
yeah, no, absolutely the right way. I think it's,
Yeah.
yeah. So, but go
But
ahead. Sorry, I didn't mean to interrupt. Yeah.
yeah, but with respect, you know, so if I have to give you an example, I don't want to disrespect colleagues, okay, but I will hold colleagues accountable if data has come, you know, past dogmas were never proven and they should be overturned by now, but guidelines and societies haven't, but these doctors are not reading, you know, what's going on. Then I have to sometimes tell my patient is, look, they're like, oh, my doctor told me I have to be on this diet, this low calorie, low fat diet. Or I'll tell you the you know, some of the most aggravating that get me riled up is when a vegetarian protein deficient person in India who's already barely getting 20 grams of protein a day has a high uric acid, because you and I know it's from insulin resistance and metabolic syndrome, but they're told to stop eating all their legumes and pulses. And these people are not planning to eat animal protein at all, not in this lifetime. So they're going to remain vegetarian. They've been told to stop pulses and legumes because of uric acid. Now that bothers me, because if anything, we needed to tell them to cut the refined carbs, the sugar, the liquid calories, the alcohol, if there's any, and any other things. So when this comes out of the patient's mouth, I'm like, I'm sorry. You need to go back to that doctor and demand evidence. You need to ask them to show you the papers, show you the science of where they're saying that from. It's very possible, and I'm being animated with you right now, just to show you how I try to use energy, but hopefully not being disrespectful, you know, but being demanding and insisting for better. But the edge comes where there's a fine line where if we now are blaming a patient for their suffering, or if we're blaming the victim that, oh, it's stupid if you don't stop your old behaviors. No, that's where I disagree. You know, I think that's where we have to be very careful. It's okay to evangelize, but the victim is not suffering on purpose.
Yeah, I think making sure to empower, right?
Yes.
So our communication needs to empower. I think you're absolutely right. It's so hard when you're dealing with food addiction, when you're dealing with sugar addiction, when you're dealing with processed food, when you're dealing with cultures and traditions and the way that it's very hard to put these all into words that people understand. It's a lot of feelings, right? When my wife says, maybe don't eat that, right? And you ask me, well, how do you feel? Right?
Right.
Seven
Yeah.
different words come to mind, you know, upset, annoyed, agitated, stubborn, oppositionally defiant, right? So we're
Yes.
dealing with profound emotions. And when we're dealing with emotional topics, like your doctor has disempowered you, disenfranchised you, the governments have told you to eat more grains and bread, and 50%. The CDC up until 2022 said get 50% of your calories from carbohydrates if you have diabetes, which is a crime in my opinion, right? When you're really processing this, I think people don't, it's hard to put it into words. It's hard to be a professional scientist in an ivory tower or a professional clinician. I mean, I know there's a fire in you that's like, this is wrong. And
What's wrong?
the proper words are expletive words that I can't say, right?
Right. It's criminal. I mean, it's murderous. It is so frustrating. I mean, I have parents in my children's school, and we do this volunteer lunch thing where parents come in to make lunch together. And these are supposed to be healthy parents feeding the kids healthy lunches. And she's telling me, oh, I have your diabetes doctor. I have diabetes. And she's like, ever since I've had diabetes, I switched from this to this. Or ever since I've had diabetes, I buy this kind of rice instead of that kind of rice. I'm like, this is not, are you better? Did your medication burden go down? And we're sitting there making lunch. I'm not even her doctor. And I want to just really lose it. Is like, I'm sorry. this is not making you better. So you have to just, sometimes be forceful and be that citizen who is going to stir the pot and kick up some dust and shake people out of, well, hello, I'm asking the awkward question. Did that change make you better? And sometimes people get hurt. And at times when I get really aggressive, like if a patient is sort of really sort of messed up in their head and they're struggling, I might become more crystal clear. And I tell them that, listen, if the worst thing that happens to you in your journey of diabetes is that I hurt your feelings one day, I'll take it.
Yeah. Yeah. And I think, when we're talking about diabetes, we're talking about amputations, heart attacks, cancer.
Exactly.
And and I know as an endocrinologist, you see a lot of patients with type 1 diabetes who die 10 years younger than the average person, which is a shame. Not to mention, the overwhelming majority are hospitalized at least once in their life for DKA. And I think what I imagine, and maybe you can tell me when you see these patients, and you said having problems, really understanding, how do they feel when they come to you, these patients, and they're really struggling and they're having lots of problems, and you are telling them something that is completely different than what they've heard. I mean, I know you've cared for more than 2,000 patients, and I'm just, I know you recognize and you're paying respect to the idea that, hey, look, some of this is not controversial, but at least, we have to be respectful and cautious with our commentary. But, you get these patients that come to your office, they're truly, you're seeing their blood sugar meters on their CGM, especially the type 1 patients, go up and down, and the harm that's going on to them. And they are shocked when they hear your message. And they're like, but wait a second, my cardiologist said this, and my other endocrinologist said that, and my primary said, I need to be, eating more, whatever, grains, and I need to have more naan, or whatever is going on over there with what are those Indian sweets called? Those really, that a little bit is okay.
There's tons of them, like gulab jamun, rasgulla, and
yeah. And they're like, well, they told me that moderation is all right. I just have to dose my insulin afterwards. And, and I should have more rice and more bread with my meal and cover. Like, how do you handle that you are controversial to these other doctors, and how do you handle it when you're trying to deliver effective patient care,
Yes. So that is, now it's come with the territory, is, I suppose, being 10 years into the low carb lifestyle space in India now. The first time I started using lifestyle change for diabetes was 2013, 14. That's the kind of the patient I start my book with. I start with his story. So it's been a decade now in Mumbai, where people now know why they're coming to me. They know that if I go there, I'm going to get lifestyle first advice. So at least that's sorted for me, in the sense they're not surprised that I'm giving them lifestyle first advice. But
so you have a brand, you have a, like, they know what they're, I'm going to face a similar scenario.
Right.
So that helps, right?
That helps. Because people self-select, is if they want to be with us, they come. The funny thing though, Tro, is how I'm going on and on about us being respectful and being listeners and stuff. But still, I also have this reputation of being, she's very strict. And I think what they mean by that, because I don't put people on diets. I don't take any food away. I say, you are in charge. You are empowered to eat what you want. I want your body to tell you what goes on. Use your CGM, use your glucometer, check in 2 hours. You get to decide, do you want to treat that glucose with more medication or with lower carbs and less medication? That decision remains yours. I'm not the police. I'm not food police. And that makes them have to look at their relationship with food. They have to look at their relationship with their body. And it's almost like I'm doing the job of holding up a mirror, which, if you're not fully ready, that can feel like a bitter truth, or a strict situation where, ooh, I have to face my reality. I have to do some soul searching if I want to move forward. But to come to how it looks when you're being contrary to what their doctor said, I tell the patient, I'm like, I'm willing to have a conversation with your doctor if they're willing to talk to me about your health. Because, and I say this in my book, is your heart and your pancreas are talking to each other every day, whether your cardiologist and your endocrinologist are talking to each other or not, or your nephrologist, but your kidney, your heart, your lungs, everybody's talking to each other all the time. Hormones, that's my specialty. So I'm willing to have a talk with your doctor if they're willing. And your body's going to tell the truth. I could be wrong. Your cardiologist or your other doc, your nephrologist, your gastroenterologist, your psychiatrist, any of these other professional, your dietitian, anybody could be wrong. We just have degrees on the wall. Don't take our word for it. Your body's going to tell you the truth. And that way you won't be stuck between, well, someone said that and someone said that. Once you know it for yourself, you're empowered to be in charge of your decisions. And I think that resonates to them is she's not trying to be right. She's trying to empower me so I know how to make my decisions.
The importance of patient empowerment is so critical in this field, besides the diet prescription, like you said, which you don't even focus on, besides it's truly patient empowerment. How do you remove one barrier and then remove the next barrier and then remove the next barrier? And those barriers are sometimes social, they're sometimes medical, they're sometimes psychological, they're sometimes physical. You're
Or
absolutely
knowledge.
right. Yeah.
Knowledge.
Or awareness. Yeah. Just lack of awareness
Yeah. I
absolutely.
think it's the biggest area I think we make a difference is my degree should serve you in a way that you don't have to have gone to medical school to know how to function get your body to function properly. If that's one advantage I have is I did a heck of a lot of studying so that you don't have to. So let me transfer that knowledge to you so you become your own expert.
Yeah. Yeah. And really that's what we need to do because the patient is their own expert. We're mere consultants, I'm curious. I know you have a multidisciplinary team. Can you talk a little bit about that and the sort of multidisciplinary approach? I mean, you've been doing this so long that you probably are light years ahead of most people. So talk a little bit about how your care has evolved over 10 years and that multidisciplinary approach.
Yeah, sure. So I was attached to a hospital. I was a hospital endocrinologist in 2013, just like all of us, clinicians are born. We are trained in hospitals, medical school is in a hospital, residencies in a hospital. And then a lot of us remain consultants attached to a hospital. And so your daily commute every day is to a hospital. And that was my story. Finally, in 2016, I realized that this lifestyle first approach that I'm trying in my room in the hospital, I'm not feeling like I have my hands in all the buckets the way I want to, because I'm having to share let's say I want to give a nutrition referral or an exercise referral or a stress management referral. I have to share those resources with one dietitian or physical therapist or, counselor who is common to the entire hospital, and they have to cater to what the majority is already doing. I'm not able to separately have them do things my way. So in 2016, I left because I wanted to bring everything in-house and just oversee and have one consistent message go, because, sometimes other clinicians don't exactly say things the way you do, and it can create a confusion for the patient. So I brought in mental health in the form of spiritual counseling. I brought in exercise with a physical therapist on site, and I brought in a nutritionist / dietitian. And soon I had a diabetes educator with me as well. I also took the diabetes educator test and certification, and I also took the personal trainer certification. I took a mindful eating facilitator course as well to learn about emotional eating and things like that. So a lot of multidisciplinary stuff I was experiencing what else I can do besides prescribe drugs to people because we don't know any of this stuff in school, and then built a team around it. And so now after the pandemic, it's been about 4.5 years now that we migrated online. And so everything is remote now. We're able to have 3 6 months coaching programs I'm very involved with every patient. I have a pharmacist who is a doctor of clinical pharmacy. She helps me track the medications and blood tests. I have 3 coaches right now, and we will expand as you know, as the universe pushes us. Right now there are 3 coaches. One is a PhD in muscle mass and diabetes, so sarcopenia and diabetes. And she's also a nutrition expert. There's another one who's a doctor of homeopathy who also has trained in my way and has taken some of the Nutrition Network courses so that she gets what we're doing. And I have another dietitian who this is her second career, and she's doing it because she wants to give back to society. She's seen people in her family get transformed, and she gets so much reward out of doing this. So these are like the core team. My husband actually has helped big time with, and he's a tech guy, he's an MBA, but he helped me build our app. We have a lifestyle tracking app, and we also have an electronic health record, which is integrated with the app. So the patients are logging their lifestyle in our app, and that comes up to us for coaching so that we can actually help monitor. And then if they ever put on a CGM, we're able to see that as dashboard partners and look at it. And then we have chat support with them consistently for like 3 to 6 months. We've built communities where once you finish your program, you stay with us for life, like an alumni, because once you leave our sort of group, when you step out in the real world, you're again a minority voice, and it's easy to get the reverse brainwashing happening again, where people will start questioning your sanity. So at least with us staying together in a community, we stay connected, we stay motivated, we talk, we do little webinars like this once in a while, we do a book club reading once in a while, maybe an interview. If there's been a great success story with a patient, we'll do like a Zoom live and just get one of them to come on and talk. So that way people feel connected to relatable, experiences of others.
That's awesome. I mean, it's amazing. It's just such a mirror of what we're doing here in Toward Health, and makes me super excited that I feel like you're my sister. Gosh, I have personal training certification. I'm a health coaching certificate. We developed an app, and every single thing you listed, it's like we're doing. So it makes me feel like I have met family.
Yes.
So I cannot say keep it up. You give me inspiration. You keep me inspired. I'm curious, we talked a little bit off the air on, and I'm going to shift a little bit here. You're doing amazing work, by the way, and
Thank
that.
you.
I want to shift a little bit because as an endocrinologist, one area that I've been very passionate about, I think deserves more attention, is the type 1 sort of, the people with type 1. And, for the people, the listeners who don't know what type 1 diabetes is, it's typically the destruction of the pancreas or the severe impairment of insulin release, typically from autoimmune disease that requires lifelong insulin. And just as a little background, that, and we talked about this all off air, but I'm going to say it again for the listener. The lives of type 1 patients are so disrupted. They have anxiety about their insulin. They have to check their blood sugars multiple times per day. They're at such high risk of death from hypoglycemia, of overdosing on insulin. And the financial implications of this disease, the socioeconomic, like the psychological impact of this disease, what they can eat, what they can't eat. They are under such an increased burden. I've mentioned this already. They live sometimes 10, 12 years younger, up to 16 years younger. They lose 16 years of life. And this group has been told for the past 50 years, eat whatever you want and dose insulin. And so, you're an endocrinologist, and I know you're dealing with these type 1 patients. And, can you give some of your own thoughts and your own feelings about type 1? I feel like we talk about food addiction and lifestyle, and we talk about behavior change and coming off meds and reversing diabetes. But this group is such a group in need. And I would love, if you can sort of give your thoughts about this community, the insights you've learned, and what you think that this group would benefit from, or what they need, or how we can more advocate for them.
For sure. No, and I'm glad you're pushing for it. I felt strongly you know, disheartened, sometimes to hear stories of people with type 1 who really felt neglected almost by the healthcare system is, oh, sugar's high, take more insulin. Oh, sugar's low, eat more carbs, eat some sugar. And that's it. Those are the two sentences they're told. And that is the most reductionistic way of trying to treat somebody. And it's not sufficient at all. People deserve much better than that. And to be honest, when I moved, so I've spent half my life in India and half my life in the US in almost like sections of 10 years each. And when I made the last move in 2011 from the US to India, I came with the diabetes educator training. I took that in the US, that training and took the test because I wanted to get in the diabetes educator's role as I was coming back to India because I'd been out for 10 years. And I was shocked that nobody in the type 1 community that I saw knew about carb counting. Not one. And so they were on fixed dose insulin, which meant take 5 units, 5 units, 5 units, no correlation being made with what they've eaten. So if the person by mistake or unknowingly had more or less carbs, that's going to make the sugar go like this, the glucose go like this. And they have no idea.
This is up and down, just for the
Yeah,
listener, it's
for the
like
listener.
high gyration, right? Up and down, have a high glycemic variability, which is such a low quality of life associated with such bad things.
Yeah, I've seen people go from 40 to 400 in one day, every day almost, where it's like that's normal. Yeah, sure, every day I'm either 40 or 400. And then to the point where as long as they're not in a low, they don't want to even check. Let it be 250 all day, but just leave me alone and I won't check for days at a time. I'll just skip some insulin, let it ride high, sit with the A1C 8 and 9. And this is what is shortening their life because they're being mismanaged. And then they just get so frustrated and burnt out by the whole thing. And it was particularly worse when I came to India because we didn't have a robust diabetes educator interface for the people with type 1. Whereas in the US, I was very well protected. We have resources. It's obvious that someone gets pump education, they get insulin education, carb counting education, and all this is being taught to the person with type 1, how to manage hypoglycemia, how to use your glucagon pens, the 15-15-15 rule, so many tips and tools being shared with them. And I saw most of that was missing in the person who came to me with type 1. Fixed dose insulin, pre-mixed insulin. Pre-mixed insulin was such a terrible way to go about it because the doctor was trying to do it to keep the patient compliant because instead of 4 shots a day, it's 2. Now I get that. Nobody wants multiple shots a day, but it was giving them, again, this terrible control is they have to always be on guard. Is if it's going to be low, I have to gobble some carbs and sweets. And if it's high, then I'll just poke some insulin again. But there was no method to this madness. It was just completely reactive and unscientific. So when I was writing my book, I had to really dedicate a whole section to it of what I've learned over the years of being here, of being a diabetes educator on the ground for all of my patients with type 1. And for the first few years, I was giving out my cell phone only to the people with type 1 in India because they didn't have anybody. There was no such concept that I can reach out to my physician in the middle of the night or somebody on call. There was no thing like that. And they were really isolated. So now they don't need to call me because luckily they've been empowered and we've just made so much progress with each of the people we've worked with. It takes time to understand their body pattern. What's your carb requirement or what's your insulin carb ratio in the morning? What is it in the afternoon? If you eat the same apple, let's say, at morning, afternoon, and night, you might have a different insulin requirement for the same apple because your body has a 24-hour clock. What's your fasting insulin requirement? We had to, break it down. There's something like the dawn phenomenon, which is around 4 a.m. The glucose will start to spike. So we need to match that artificially because we're trying to copy what the pancreas should be doing by matching your insulin with that. It's very difficult on the 4 times a day shots, but I still have patients who, because of budget reasons, again, insurance does not exist in the outpatient setting in India. So if you have to get yourself an insulin pump, you're paying for it yourself. So if it's a family that has to decide on a pump, they could be thinking it could be one international holiday, it could be a scooter, or it could be a pump.
Yeah. Yeah.
So it's very hard. And
It's not
so
easy. Yeah.
it's not easy. And so they're scraping together to get these things purchased. So the ones who decide to go with multiple daily injections, we have to give them an option. Of course, going low carb has helped so many of them. And since you and I both are strong advocates of low carb, I'll give you the example I teach when it comes to type 1, and I say this in the book, is, this whole thing that we're talking about. So I describe living with type 1 with a high carb lifestyle, I describe as Formula One racing. It's high speed, high risk, high acceleration, high deceleration. If there's going to be an accident, it's likely to be very dangerous. And living life with type 1 diabetes on a low carbohydrate lifestyle is like driving in boring evening bumper to bumper traffic. You would much rather be in the boring traffic, bumper to bumper, where even if you touch somebody by mistake, the damage is not going to be so severe, not so dangerous, and it takes minimal course correction to come back. And that's just what happens when you go from being high carb, high insulin to a low carb, low insulin pattern with type 1. And people see that, and people are able to sort of get, time in range is a big thing that, bothers a lot of people, because there's so much, almost like you become a perfectionist, is you don't want to go too high because then people say your organs will get damaged. You don't want to go low because that could kill you today. And on both ends, you're living with big time danger signals on both sides. So we're actually, because of this conference that just happened in San Diego, I made so many new friends, and I met so many smart people that I met Andrewkutnik.
What an
And
amazing scientist in the
what
type
an
1
amazing,
space.
so
Yeah.
smart and so genuine and out there to help people, and generous with his knowledge and his time and wisdom. And so I'm going to have him come and speak to my audience of type 1 in India, because they're trying to exercise, and he understands exercise and nutrition physiology. And, in type 1 exercise, you're trying to do something good for yourself. And even within that, there's danger. It could go too high, it could go too low. And it can feel very frustrating if we don't help you decipher these patterns and prepare you so that you can exercise safely while taking insulin. What type of snack to take before the workout, things like that. So we're going to have an interactive session with Andrew very soon. And there is a big type 1 community in India that's, almost self-taught. They use Dr. Bernstein's book. And I hope that my book, and I've put type 1 on the cover, it's a big section in the book for them. I hope that this book, is up there with Dr. Bernstein's book. Once you read it, I want feedback. It needs to help the type 1 community feel like they've got a place to go and read stuff that'll help.
Oh, it absolutely will be. It absolutely will be. And you're such a pioneer. You're such a powerhouse. Andrewkutnik is amazing as well. I have to give him big credit. You mentioned him. And oh,
Yes.
what a credit to Dr. Bernstein.
Yes.
He's been evangelizing the space for the past, really 40 years, and still practicing, by the way. And
Yes.
another shout out to the Type 1 Grit community, which has been an amazing Facebook group. Anybody out there with type 1 should go visit that community. And
Yes.
pretty soon you all, everybody will have access to the SMHP position statement on type 1, which I'm really excited will be released, as well. We're going to wrap it up here. Dr. Roshani, I'm so happy to have you back here. I'm so proud to see you as an author, as a CEO, as an app, person. Your book is amazing. You were so inspirational. Everybody contacted me after the San Diego conference saying, "Who is the star? We're so happy to see her. How have you guys hided her away in India for so long?" And I was like, "No, we interviewed her last year. We she lectured for she lectured for us." And I'm so just happy. You deserve success, and I hope you find more success. Guys, if you're listening to this, go get her book, and we'll put it in the show notes. It's available on Amazon, so don't be don't be shy. Go get it. If you have type 1, if you have somebody with type 1 in your family, turnaround diabetes, it is on the Amazon stores. Go get it. Yeah, go get it. Any parting words for us, Any parting words? Where can people find you? Let's start with that.
Sure. So I think our tags are there on Zoom. So it's Reisaan Health, REISAAN health.com. That's our website, and we try to keep that active and updated. I'm on Instagram. I'm trying to build up my presence there, do a little bit of YouTube, messing around with social media. I can't say that it's my strength, but trying. And I think let's grow the tribe, let's grow the community. I should give a shout out. You guys just recently brought on Dr. Mariella Glant. So we realized there are 2 low carb endocrinologists in the world. If there are more of you out there, please come forward. We need to know where all you exist in this planet, because I think we need to represent the endocrine voice and help all our medical professionals, our patients, families, communities. We need to do this together and help each other. So thank you, Tro, for what you do with Toward Health and with Low Carb MD.
I'm trying, yeah, and the SMHP, and I've been
Yes.
trying. Look, thank you so much for coming, and we'll put the book in the show notes, and we'll put all this in the show notes, all the social. Thank you for coming.
Thank you, Tro.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.